Hi, everyone. Thanks for joining CDTRP's Level Up webinar series. I'm Nick Murphy. I'm a postdoctoral fellow with the Departments of Medicine and Philosophy at Western University in Ontario, Canada, and I'm also a CDTRP trainee. CDTRP is hosted by the University of Alberta, and we respectfully acknowledge that we're located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. I'd also like to acknowledge that I'm speaking to you here today from the traditional lands of the Anishinaabe, Haudenosaunee, Lenapehoik, and Chinungkton nations. I encourage you all to put your land acknowledgement in the chat box. So today, CDTRP is excited to welcome Dr. Sean Dix, who will be presenting on the topic of the relationship between families of deceased organ donors and transplant recipients. Before I introduce Dr. Dix, a couple of housekeeping notes. Today's webinar and discussion are being recorded and posted to the CDTRP website and YouTube channel. So please turn your cameras and mics off during the presentation. Once the presentation's over, we'll ask you to turn your cameras on, and if you have a question or comment, to please ask our presenter directly. You may also want to just add comments or questions in the chat or privately message CDTRP Q&A if you prefer to keep your question anonymous. So it's my pleasure to introduce Dr. Sean Dix. Dr. Dix is a clinical psychologist who has 20 years of experience supporting both families of organ donors and transplant recipients. While it's rare for him to have contact with a donor family and recipient linked to the same donation transplantation event, his contact with families who have lived experience with organ donation on the one hand, and patients who have received transplants on the other hand, has provided opportunities to explore how their journeys become linked when they attempt to make sense of and find meaning in their respective crises. Dr. Dix recently completed his PhD at the University of Canberra in Australia, and his study explored the bereavement experiences of families of potential organ donors. In preparation for the empirical component of his research, Dr. Dix completed several systematic literature reviews, which each explore aspects of the experience of families of organ donors, transplant recipients, and healthcare professionals. One of those reviews sought to understand the relationship that develops between families of organ donors and transplant recipients. Drawing on the literature from both sides of this relationship, a number of interesting observations were made. So today's presentation is going to focus on these observations and Dr. Dix's experience supporting families of organ donors and transplant recipients, and the findings of recent international studies that have explored the relationship and needs of the parties involved. So Dr. Dix, thank you very much for coming, and please take it away.
It's a pleasure. Thanks, Nick. I've got a bit of cough at the moment, and I'm glad I pre-recorded the presentation. I'll speak afterwards.
Thank you.
To start, I would like to provide some context for our discussion by exploring the story of the first heart transplant. 54 years ago, medical teams across the world were prepared for the world's first heart transplant. For the operation to happen, several conditions had to be met. A patient sick enough to need a transplant, but healthy enough to survive the operation was needed. And a grieving family needed to give permission for doctors to transplant the heart of a relative who had been pronounced dead. This was a year or so before the brain death diagnosis was officially recognized. The donor, the recipient, and the medical team needed to be at the same hospital at the same time. These conditions were met at Groote Schuur Hospital in Cape Town on the 3rd of December 1967. The day before, 25-year-old Denise Darfel had been involved in a tragic car accident not far from the hospital. Denise, her two younger brothers, and her parents had been on the way to visit friends. They stopped opposite the bakery on the main road, and Denise and her mother crossed the road to buy some food to take with. When they were returning, a speeding car hit them both. Her mother was killed instantly, and Denise was rushed to the hospital in a critical condition. Doctors later explained to her father that her injuries were not survivable. The possibility of organ donation was raised, and Edward Darfel agreed. When asked later, he said that it had taken him about 4 minutes to decide, and that during that time he could only think of his daughter. He told doctors that if they were sure that they could not save her, they could use her organs to save others, because that is what she would have wanted. Louis Washkonski, a 53-year-old grocer, was at the hospital too. He had suffered a number of heart attacks. It is reported that his body was bloated, he could hardly breathe, and he was near to death. The doctors and his family, however, recognized his spirit and the courage with which he fought to survive. Louis Washkonski and his wife Anne were willing to try the possibility of him being saved by somebody else's heart. The head of the cardiothoracic surgery department at Groote Schuur Hospital at the time was Professor Christian Barnard. Over the previous months, he had gathered together a team to assist him to perform a heart transplant. Denise's death, her father's consent, and Louis' willingness to try this new procedure made it possible. Surgery commenced shortly after midnight on Sunday the 3rd of December. Denise and Louis' operations took place in adjacent theatres. Apart from her heart, Denise also donated her kidneys, one of which saved a 10-year-old boy. Just before 6 a.m., her heart, now in the chest of Louis Washkonski, was electrically shocked into action. 20 years after the first heart transplant, to mark the anniversary of the event, a reporter told the story from his point of view, describing how he had been sent to Groote Schuur on Sunday the 3rd of December 1967 to investigate rumours of a heart transplant. He reported that when the operation had been confirmed, other journalists started arriving from around the world, each trying to find out more than the other. The journalist described standing in the corridor outside Mr. Washkonski's room, waiting for a chance for a photograph. When Dr. Barnard was tracked down, it took much persuasion to get him to agree to an interview, and then he would only allow a photo if it included members of his team. In the days that followed, other healthcare professionals were persuaded to be interviewed too. The journalist also noted that 5 days after the transplant, Mrs. Washkonski was able to see Louis for the first time. It was reported that she came out of the room after the visit excited and happy about how good he looked. Unfortunately, Louis Washkonski died 18 days after the transplant with double pneumonia, attributed to his suppressed immune system. In the year that followed, there were 90 heart transplants internationally, and similarly, each time, journalists were keen to share the stories of the recipients, the donors, and the healthcare professionals. However, both donor families and recipients complained about the way that their details were leaked by medical professionals and made public by the media without their permission. In response, rules and laws were introduced to protect confidentiality. On the anniversary of the first transplant, a newspaper interviewed Mrs. Washkonski, who said that she would always be grateful to Mr. Darfel and Dr. Barnard for the chance given to her husband. When he was interviewed, Dr. Barnard spoke about how understanding of post-transplant care had improved over the year, contributing to better outcomes internationally. Hearing this, Anne said that knowing that doctors had learned from her husband's experience and were able to help others was comforting. She said that for her, that meant that her husband had not died in vain. She mentioned that she would later that day be visiting Mr. Darfel, and the reporter asked her for her thoughts on rules that were then being implemented to keep future donations anonymous. She replied that her husband had been upset to hear that he had received a young person's heart, and she therefore supported the new rule. Denise's father was also interviewed on the anniversary of his daughter's death, and said that while he mourned the death of his daughter and his wife every day, he did not regret giving permission for the donation of Denise's heart. The newspaper reported that at the school that Denise had attended, the Denise Darfel floating trophy was awarded to the school's best scholar. 2 years later, when Mr. Darfel died, also of heart trouble, it is reported that Anne Washkonski was at his deathbed. The Heart of Cape Town Museum is dedicated to the story of the first heart transplant. A picture on display there portrays the connections that develop between recipients, the donor and their family, and healthcare professionals. While evolving laws were created to protect donor families and recipients, laws took autonomy away from those who may want to make contact with each other. To create a bridge between the need for confidentiality on the one hand and connection on the other, the practice of facilitating the exchange of anonymous correspondence was developed. Over the years, both donor families and recipients have expressed appreciation for this method of communication. One of the reviews conducted as part of my PhD is particularly relevant to today's discussion. As part of that review, I combined literature from the organ donation and transplantation fields to better understand how anonymous correspondence is helpful. After considering findings of previous studies, I proposed that donor families and recipients each face several struggles as they make sense of the organ donation and transplantation context. If these challenges were seen in terms of meaning-making, it is as if each have an important puzzle to complete that has implications for their identity, adjustment, and relationship with the donor. I suggested that they each hold pieces that would assist the other to complete their respective puzzle and adjust their lives after organ donation and transplantation respectively. Anonymous correspondence, facilitated by organ donation agencies and transplant centers, offers one way for the parties to learn about the pieces of the puzzle that the other holds and gain a more complete understanding of the implications of their decisions. The following diagram, adapted from the online article, describes in more detail how this may occur. I proposed that when recipients write letters of sympathy and gratitude, the donor family's pain is acknowledged and the value of their decision is confirmed. This is reassuring and assists families to understand the difference that the donor has made in the lives of others. This is often comforting, contributing to satisfaction with their decision and adding to the deceased's biography. When the donor family writes, expressing hope for the recipient's recovery, recipients realize that their health is important to the family. Any guilt that they may have had about living while the donor family is grieving declines, and treatment compliance has been found to improve. Some recipients may experience identity disruption when thinking about living with a part of someone else. When donor families share information about the donor as a person, these recipients have been found to be less anxious, facilitating adjustment to life after transplant. Sometimes, people find it difficult to write a personal and sensitive letter while at the same time strictly protecting confidentiality and not mentioning names, places, or other identifiable details. In such cases, I have found that by extracting themes from the details, donor families can accurately portray their loved one and recipients can describe their experiences while adhering to guidelines. Moving on to the other outcomes of the review, I would like to explore in more detail the position and roles of organizations involved in the organ donation and transplantation fields, the experiences of transplant recipients, and those of families of organ donors. The World Health Organization has stated that the personal anonymity and privacy of donors and recipients must always be protected. Countries and states within countries interpret such statements, and the emerging laws have implications for donor families, recipients, and healthcare professionals. In addition, organizations need to manage ethical dilemmas when decisions are made. For example, as has been noted, laws may protect confidentiality, but diminish the autonomy of those involved. Treating teams also have to identify opportunities for care in this unique context that consider both the grief of the donor family and the adjustment of the recipient, as well as the meaning-making of healthcare professionals working in this context. Too much caution and concern that harm may be done could contribute to missed opportunities for people in each of these roles. Over time, the context and the world around it have changed. For example, when the first heart transplant occurred, organ donation and transplantation happened at the same hospital, in adjacent theatres. It would have been possible for healthcare professionals, family members, and journalists to find out the details of the donor and the recipient. Today, organ donation and transplantation events can involve hospitals and treating teams in more than one country, making it easier to separate information about the parties. On the other hand, the internet and social media make it possible for people to gather information that may make donors or recipients identifiable. There is a need to understand and respond to these changes in suitable ways. Research must improve understanding of the benefits and risks related to emerging possibilities so that suitable responses are developed. Ethical principles should be carefully considered, especially when they seem to be in conflict. For example, individual rights and autonomy need to be balanced with the need to preserve confidentiality and to protect people from potential harm. National organizations also need to consider the impact of decisions on the organ donation transplantation system as a whole. For example, allowing contact between donor families and recipients may contribute to meaningful stories that raise public awareness, but could also contribute to problematic contacts that may cause hesitancy and negative connotations to arise in the field. Considering the experiences of recipients, there are the medical aspects of managing deteriorating health while being on a waiting list for an organ, and then receiving a transplant, and having to recover from the operation. In addition, recipients could find their sense of identity being disrupted if they were to associate personality or behavioral changes post-transplant with the donor. Other recipients may develop an overly close psychological relationship with the donor, which may be based on real or imaginary factors. And some may experience intense sense of responsibility to ensure that the donated organ is kept healthy. Recipients often say that they think about the donor and their family, with some experiencing guilt, with the sense that they will never be able to adequately express thanks for the gift that they have received. These experiences could be distressing. Because recipients need to adapt to strict treatment regimens, their treating teams may fear that such stress and guilt could interfere with the treatment compliance. Considering the experiences of families of organ donors, They will have encountered confusing in-hospital processes while coming to terms with an unexpected death. The family may have concerns about how these factors will influence future individual and family functioning. The death will have disrupted usual family patterns. At the same time, the family would have had the task of coming to a shared decision about organ donation that considered the attitudes, knowledge, and views of its members. Many families report thinking about what the patient would have wanted, which links the decision-making process to the development of a post-death psychological relationship with the deceased. In the weeks and months following their time at the hospital, family members will need to attend to a number of psychosocial tasks, some of which link their grief to their decision about organ donation. For example, they will need to consolidate their understanding and to make peace with decisions made at the hospital. Some may need to speak to healthcare professionals to clarify aspects of their experience, or obtain some kind of reassurance that they did the right thing. Nevertheless, post-transplant, some families may be at risk of depending on recipients for a sense of connection to their relative, or a strong connection with a recipient could contribute to secondary grief experiences if the recipient dies or the organ is rejected. At the hospital, initial hope for the patient's survival transforms to hope for a peaceful death, and in the weeks following may incorporate hope for recipient's health. As they make sense of and consider responses to the context, they may think about and ask questions about recipients. Information about recipient progress may assist them to find meaning and resolution. At the same time, family members will experience internal struggles as they adapt to new roles and responsibilities that are necessitated by the death. The meaning-making of donor families and recipients becomes connected. Both parties faced death and hoped for life. Recipients may be coming to terms with guilt and identity disruption, or have a strong need to thank the donor's family. And members of the donor's family may wish to receive confirmation that their decision made a difference that would have fitted with the deceased. Their decisions and the actions that followed in both cases contributed to the deceased's biography, the story of their death, and the development of psychological relationships with the deceased. Both parties will have experienced events that have implications for their identity and roles, with recipients being able to engage in more activities than before, and perhaps wondering if post-transplant choices or emerging characteristics are linked to the donor, and members of the donor's family becoming single parents, widows, etc. as a result of the death. The changes in their life paths and capacity may leave them searching for direction. While wanting to know about each other, parties may have concern that approaching the other in attempts to resolve their own ambiguities may be inappropriate or even harmful. Present laws preventing contact seem to reinforce this idea. Nevertheless, in cases where the sense of connection between donor family members and recipients is strong, they may feel that their narrative is incomplete if they do not find out more about each other. They may hope for contact, which could help them both make sense of their decisions and experiences. For recipients, the purpose of contact may be wanting to thank the donor's family, get to know more about the donor as a person, and perhaps more about their health while they were alive. Donor families may want to understand the concrete details of their decision, rather than having an abstract description that somebody was helped. And they may want to share information about the donor as a person. Several options exist for those wanting contact. Some may use anonymous correspondence, which is offered by many centres. It has been found, though, that while both parties often feel that a letter from the other would be helpful, they themselves are hesitant to write first. Not understanding the potential value of correspondence, parties may decide not to write. While in some countries, like Israel and the USA, centers can facilitate direct contact if both parties are willing, in most other countries, the law prevents this from happening. In response, options and practices have emerged for those hoping for contact. For example, in Australia, a moderated Facebook page was initiated by an independent group of donor families, Donor Families Australia, to provide an opportunity for donor families and recipients to share their details online, hoping to find a match. Whichever means of contact is available, it is important that expectations are realistic and that participants' choices are respected. An intermediary would be helpful, as they could guide participants as they evaluate expectations and readiness for contact. On the systemic map, I have highlighted several qualities that may emerge in the organ donation transplantation context. These include novel ways to offer care and support, empathy and understanding for the positions of the various role players, anonymous letters, which often precede direct contact. The narrative of donor families and recipients become further connected. Both parties experience unique opportunities for meaning-making. Parts of the deceased donor are alive. The recipient experiences improved quality of life and adherence to their treatment regimen. All role players gain a better understanding of the psychosocial features of the organ donation and transplantation experience. Related to policies and practices in specific countries, role players will either understand and accept the options made available, or may experience mistrust and frustration with a system that they feel does not validate their needs. These matters have been the subject of several studies, and I would like to end the presentation by providing interested attendees with a list of recent articles dealing with some of the issues raised today.
Wow, thank you, Dr. Dix, for that fascinating presentation. You've done a wonderful job distilling an enormous amount of research into a very accessible presentation. So thank you for that. And thanks as well for coming, even though you're feeling a bit under the weather.
It's a pleasure.
Yeah. Just a reminder to everyone to please turn on your camera if you're comfortable. You can post questions in the Q&A box. You can ask anonymous questions by contacting CDTRP Q&A directly, or you can ask questions of Dr. Dix directly. I might just get us started with a question from me, kind of a two-part question. So I ask because there is this movement in Canada now. We now have 3 provinces that are already or planning to begin facilitating mediated direct contact between deceased donors' families and organ recipients with identity disclosure. So I guess I'm wondering about this change in attitude towards mandated anonymity in deceased donation. So I guess 2 parts. You mentioned that several jurisdictions have allowed direct contact for some time now, such as Israel and the United States. So is there any findings you could comment on about what the experience has been there, what challenges there have been, and what benefits have arisen? And then more generally, what do you think has motivated or precipitated this movement towards greater openness in deceased donation?
Thanks for the question. I only know about what I've read in research articles and so on. And as I understand, donor families and recipients in those cases are encouraged to use anonymous correspondence initially for a given period of time, which might be a year or so, or maybe less, I don't know exactly, in order to kind of check out their motives, get to know each other that way. All of that would be mediated by somebody at a transplant agency or a donation agency who would be able to highlight any risks that come out of the exchanges, discuss these with the parties, and gradually lead towards the disclosure so that it isn't just a cold disclosure and throwing people into the deep end. And in particular, the articles that I've read from Israel demonstrate that the coordinator, the intermediary, has a very important role to play. As far as what has prompted it is concerned, I added the bit about the first heart transplant to demonstrate that these matters have existed for forever, as long as transplantation has existed. They're not new matters. I think what has changed is our response to them, and perhaps our acknowledgement that while keeping everything anonymous suits certain people in certain ways, it doesn't meet everybody's needs. And I think that is the issue that is being addressed at the moment, that for some people, for their needs to be met, we have to be more open about how we respond.
Thank you very much. I see Leonard in the chat box has written, I love the way this was presented. As a living donor, I see so many parallels to living donation, privacy expectations of relationship, anonymous correspondence, and so much more. I wonder if I could build a question on that. Do you think that these considerations you just mentioned towards openness apply as well towards correspondence or direct contact in the living donation context?
I would imagine yes, that a donor living or the family of a deceased donor, I would imagine that they would have interest in the results of their actual decisions. And those interests may change over time, where people might initially be happy to remain anonymous and maybe even request that they remain anonymous, but later on want to actually meet the people involved. Or the people involved might make requests, and the person would have to reevaluate whether they will want to remain anonymous, or in the light of the new requests would like to reconsider. So I'd see it as an evolving relationship rather than one that is determined at a given point in time.
Thank you. We have a question or comment from Rink.
Yes, hi. That was a very interesting presentation, and having gone through this process, my donor. So I got a new heart, and so he was in Nova Scotia, and so the letters were very awkward because it was clear that they wanted to share a whole bunch of information, and it was all redacted out with whiteout. So the letter was just very strange. We were trying to figure out if they would like contact based on sort of the tone of the letter, and so we were very hesitant to do anything. And in the end, so it was like, and so these letters went back and forth a few times, everything sort of redacted out, and it was clear they were trying to share the name of the son and all that. It was their son that had passed away. And in the end, the internet is a wonderful thing. I ended up getting on Google Earth, went down, looked at the cemetery where he was buried, contacted the pastor, sent him an email saying, here's my information. if they would like contact, that would be great. But if not, absolutely fine too. It's up to them, really. And suddenly I was at Union Station in Toronto waiting for the train. The phone rang, and it was the dad of the son whose heart I got. Then we ended up, but this was sort of 7 years later. And in the end, they already had a relationship with the kidney recipient, the liver recipient, and the pancreas recipient. They were already, I mean, it seemed like they were all connected there. They were all in Nova Scotia. But so, and there were a lot of opportunities where if the process would have been less awkward and stilted, and exactly as you drew out in your diagram, you go through all these various phases. You're worrying about how they feel, and that's all very important. You have to go through a process, but it was definitely the natural course of events based on how everybody felt was basically stopped for, I'd say, 7 years because of how awkward it was. And in the end, we went to visit. We flew out there. They were unbelievable. They had probably 40 family members. They had stethoscopes. They're listening to the heart, but it was because they were extremely open people. And for them, that worked. And for us, that worked. I'm sure it's different for everyone, but I wish that 7 years would not have taken so long. And they did as well. So it's almost like the system has been written by people that have not gone through this. And maybe they've had bad experience. I know bad experiences happen too, but it should be easier. I felt it was really not a very nice process for us. It could have been way better. So.
Yeah, thanks for that. And I think one of the things you highlight is that if people want to make it happen, they'll make it happen. And the difference then is that they're on their own. Your experience was a good one, but other people's experience might have their challenges and so on. And if the law doesn't allow health professionals to be involved, the people are up to trying to figure it out on their own. And I think they are at a disadvantage then.
Thanks for sharing your story, Rink. That's an amazing story. Do we have a question from Lindsay, or was that?
No, I can't open my screen up because you guys have shut me off. My video.
Sorry there. So now you know how the donor families and the recipients feel.
There, I just have a comment. First of all, thank you. That was such an amazing pulling together of everything we go through. I'm actually a bone marrow transplant survivor. And based on Rink's information you just shared with us, it almost sounds like the individual transplant groups, like whoever the coordinating group is, like for me, it was Canadian Blood Services. Each individual group has their own process. Like it's not a standard process across the board for transplantation and allowing the connection of the two parties. With CBS, you have to wait a year, and then you both have to fill in consent forms to agree. Like I sent in a consent form asking if there was a chance of connecting with my donor, and they reached out to him and said, we've had this request. Are you interested? And then from there, we were able to send anonymous letters to each other through CBS, still allowing for that chance to break the connection if you're starting to get a little uncomfortable. And then we progressed on and we eventually met. But it's even in Canada, apparently it's not standard.
Yeah, and I think, again, as with Rink's story, it shows that people are determined when they are determined. And the laws don't stop it from happening. Again, the story of the first transplant demonstrates a little bit about what went wrong in those days, where nobody was actually prepared for what was going to be happening. The way the journalists got all excited about it, put photos of donors and recipients on the same page. And I can understand people feeling that their privacy was violated then. And I think perhaps in a knee-jerk reaction, organizations and countries started making laws that were very restrictive. And again, the common thing in both situations is that the people involved actually didn't have control of their information. When it was put in the newspaper, they had no control. And when the laws then prevented connection, again, the people who were really involved had no control.
Sylvie?
Yes, thank you. I just want to add a comment on Lindsay's comment. I can concur that it's not the same thing across the provinces. My son had a second kidney transplant in January this year, and he was contacted through Transplant Quebec by the donor family 2 weeks ago. So that's not a year. And he was very happy that the family contacted him, and he is preparing his letter back. Actually, he says, I'm going to write 2 letters, one that says a lot about me and one that says not too much, and I'll see which one Transplant Quebec will send to the family. It's his way to express thank you. He was on the highly sensitized list, so his chances of getting a kidney were very, very low. And I think he needs to express that it's really fundamental for him to say, you gave me a third chance at life, and your son's death was not in vain. So I think we need to encourage that.
Yeah, just to comment on the process of meaning making that both donor families and recipients would go through, recipients and their families. This is a unique kind of event that's only been around for 50 or so years, 50 to 60 years. And there are no traditional ways of making sense of it and understanding life with a transplant or the donation of a loved one's body. So I think a lot of meaning making goes on. And that's what I implied with those puzzle pieces, is that the donor families and the recipients need each other as they making sense of what they've experienced.
Thank you. Anne, do you have a question?
Yes, hopefully you can hear me. I just switched to my headphones here. Can you hear me okay? Yeah. Thank you. The last person who was just speaking about the highly sensitized patient registry made me think of something. I don't know if anyone's really studied this before, but when reaching out to families or talking about this is and maybe donor families don't need to know this, or maybe they don't, maybe it doesn't matter, but do you think there's an understanding at all of differences in compatibility and how important one specific person may be to another person, that might have been their 1 in a million match, as opposed to somebody who's easier or harder to match? Do you think that's something that families would want to know, that their specific loved one was even more that particular, they were just this magical fit for the other person, or not? I don't know if that's ever really been studied.
I think needs can be quite specific. I've spoken to families who don't really feel they need to know much. All they need to know is that somebody was helped and that satisfied their meaning-making needs. And I've heard other families who need a lot more specific reassurance that they made the right decision and somebody's life has actually been changed around. And I think those families might really appreciate that extra information. to know that it was a really special match. And linking to the need that the bereaved have to complete the biography of the deceased person, I think that would be really good information to assist with their meaning making, to know that it wasn't just any match, it was a really special match.
Christian, if you don't mind, I'll get to you in a moment, but we have a question, an anonymous question that I'll read out. So in the recent past, there have been a couple of stories in the media from donor families sharing letters from their loved ones' recipients in the hopes of finding these recipients to help the donor family find closure in the donor's passing. Is this considered an ethical move to make in trying to make contact with the other party with or without prior consent? And how can this affect recipients who may feel pressure to provide closure and bring the family donor some sort of peace?
Yeah, so as I described in the presentation, when the laws and the systems that exist don't satisfy people's needs, they start looking at creative ways to satisfy those needs. Rink described his actions to try and meet the needs of the other party, how he had to perceive what those needs were because the letters were blanked out. So the laws don't stop people's drive. The moderated Facebook page here in Australia does that type of thing as well. It allows parties on either side to post pictures of letters that they've received, which helps then the person who initially sent the letter to say, hey, yes, that's the letter I sent. The law in Australia doesn't forbid that at all. The law in Australia is directed specifically at healthcare professionals who, unlike the people in the case of the first heart transplant, where the health professionals spoke to journalists, put pictures of the treating team up in the newspaper, which then allowed journalists to identify all the other people they needed to speak to. The laws aim to shut that down. But the law doesn't stop the families or the recipients from posting their details. I think what comes up in what you're describing is the donor families and the recipients need ongoing support from the centers that support them. So in the case that you've described, the recipient should be able to go to their center and say, I've become aware of this and I'm unsure, and receive some kind of support, helping them in the end to make an informed decision that fits with them.
Great. Christian, I believe you had your hand up first.
Yes, thank you. Great presentation, Sean, very much interesting. My question is related, somewhat similar to the earlier question. It relates to social media. As you know, within Twitter and Facebook, et cetera, someone can easily post, hey, I just had a transplant. Someone know out there, know who my donor might be. What do you think response should be to that from those governing these privacy laws and that in response to social media is so out there and it's fairly easy to get hold of somebody? Any thoughts would be much appreciated.
Yeah, so in Australia, as far as I understand, in the UK as well, part of the response to that has been to educate on the one hand recipients and on the other hand donor families regarding some of the risks of social media, that need to be careful about sharing private information, not knowing who you're actually sharing it with, and so on. So to look at social media as a tool that gets drawn into this process, but if people don't know how to use the tool, they could end up sharing more than they wanted to, having more people than they wanted to know about what's happened, knowing about what happened. So I think, again, education will enable informed choices. I think clearly we're not going to stop the use of social media, but we can help people to be more aware of the implications when they are using it.
Austin, did you have a question?
Not necessarily a question, but I'd just like to make a comment based on my lived experience. And I had a deceased donor transplant in March of 2020. And anyway, it was a confusing time at that time, but it kind of happened out of the blue. I was on dialysis for 4 years, and I was kind of into like a groove of living on dialysis. I don't know if that's really a fair comment to make, but anyway, I was surviving my life and I was doing okay for the most part, health-wise. But when I got the call, I wasn't expecting it, and it happened all of a sudden, and it was surreal. And there's a lot of things that happened between then and now. But the one thing that always, when I got the transplant, it dramatically changed everything in my life. You know, there was so many emotions involved because of my particular circumstance, but every day I get up and I'm curious about the deceased donor. But I unlike, you know, I heard the first speaker, I can't, Renick, is that the guy with the heart transplant? I love your story, man, I do. And, but I wrote to the anonymous letter. I struggled with that. And I had very little help from the caregivers, and I understand that because, I mean, they're in a hell of a dilemma, and it never changed. I just still like it, and it was like it back then, and but anyway, regardless, it changed my life, and I'm committed now to trying to change, you know, to make things better for people that are in the situation that I was in, and hoping that they don't get to the point. I mean, that's how it changed me. Before that, I was just living like the majority of people, you know, living in your bubble and not worried about people like us, really. I'm not sure if that's a fair statement, but every day when I get up, I'm not a religious man, but I still think about the person who gave me that second chance.
Thank you for sharing your thoughts,
Yeah.
Austin. Very
Okay.
fair statement to make, absolutely. I think that it's a very valuable perspective to share with us. We have Donna makes a comment in the comment box. There is a healthy way to connect and communicate, and that is really not encouraged today in Canada. So I think speaking there to the need for more support for recipients and donor families. Thanks for sharing that thought. Sandra, do you have a question?
No, just a statement. So I had this donation 25 years ago, and I was told by our ODO in Ontario that, you know, that we could write a letter, but like there was no like need to try to reach each. So my feelings on this have always been the same since day one, and they haven't changed. Is that I was fortunate. I wrote a letter and I received a letter back within 3 months from my donor's family. I don't know if it was her son or her daughter, but I received a letter, and then a year later, I received a letter from her husband. And then, like, I would write letters back and forth, and then I just happened to be in the hospital, and our ODO gave me a letter, and that's been like 22 years since. But I have done a lot of media, and so if people wanted to know, I haven't said, I guess I have said the date, but my feeling is that if my donor family wanted to meet me, I would probably honor that. But I would have some concern about the expectations, because what I do is I've adopted donor families and work with them. like sort of like they're sort of the people, like instead of my donor family, I know like, I don't know, 10 donor families that I'm really close to. But I have a hard time with the conversation that we just had about these groups that have started, and people started doing it on one that I administer for the Canadian Transplant Association. And I'm like, that's not what we're about. Our ODOs say that there's laws against this, that we're really not supposed to do this. But I would be really offended if the letter I wrote to my donor family showed up on social media. I would expect the same if I shared. I have these cards in a nice album and it's for me, but I've never shared those and stuff like that. So, so I really think what you brought up about having support and indicating how we should be communicating, and the things that, like, it's not all like, you know, rainbows and unicorns and that, like it's been showcased on TV. There's like even the donor families I've worked with, like when they haven't heard from someone, they don't understand. Well, it turns out they passed away. Or if it's someone with a child and they wanted that child to replace a child they lost. Or if it's someone who had a transplant, like myself, because of liver disease, but not because of alcohol, and I'm seen having a drink, and they're saying, like, the family's saying, well, you should be drinking. So there's a lot of things on the other side. But I think if both parties agree, there could be something. But I really think we really need to look at this whole issue a lot more before we start jumping into what I see happening right now on social media. Those are just my input.
Dr. Dix, did you want to comment on that before we move on?
Yeah, just to say that I think all those comments are valid, and that's what I was talking about, where people need to be aware of the implications. And as Sandra was saying, it could be hurtful if somebody's letter appeared without their permission. But the person showing the letter might not be aware of that. So that kind of information can be shared with people in just a general pamphlet from a transplant agency or donation agency to say, hey, here are these letters that you receive. They're really special. You should not just assume that the writer of the letter would be happy with it posted online. Their decision might be to keep it private, and maybe it's necessary to respect that. But it also comes down again to the fact that people need support from the agencies that represent them.
Thanks very much. We're pretty much out of time, but if David and Donna just have quick thoughts or questions they'd like to share, could we start with David, please?
Hi, yeah, Dave Smith, kidney transplant recipient for 25 years this year, and the past president of the Canadian Transplant Association. I really, first and foremost, I want to thank you, Sean, for the talk. It was great. And obviously there's a lot of interest around it, and it's been going on quite a while. What we've been putting on the Canadian Transplant Games for over 20 years now. And we invite donor families to participate in an open letter so that they're allowed to come and participate in a donor walk and any other little events that we have going on. What I found, though, at the end of the transplant games, they come up to me and they tell me how much that healed them, how much just seeing not the person that received their organ, but it was the person that, you know, all these kids and everybody that it benefited from their decision. And, you know, they couldn't thank me enough on that. Like, not me, but the association for bringing that on. So it's, yeah, it's important, this topic, and we're going to continue doing that as we, you know, move forward for more games.
Thank you.
Thanks for that point. That is important. We find that services of remembrance, and as you said, walks to raise awareness, that both donor families and recipients really appreciate being able to meet somebody from the other side, even if it isn't for the same transplantation event. It helps them in the meaning making.
Donna, we are just over the hour now, but if you have a quick question, that's great.
It's more a comment.
Great.
I guess my whole issue with the communication and the letters, etc. I like the letters. I just find that there's so many barriers to the letters. There's not so much. The support I had was, you can't say this, 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 and this. It was all no, 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 no. It wasn't the positive side of it. I mean, mine took 6 weeks to write the first one. It's a difficult conversation to have, because it's not something, like you say, it's only been around 50 or 60 years, and we're all pretty much unicorns in our own right here as a recipient. It's difficult to find the words, it's difficult to find what to say, but there was no real support to write it other than this very sterile piece of pamphlet that was basically lifted from the legislation. And the other thing is, the legislation varies so much across Canada. If we at least had something that was the same across Canada, it would be easier to digest. I mean, I met someone in small town Saskatchewan who's in agony because he lost his son 18 months ago. He's still having trouble with it, but he's in small town Saskatchewan. Who is there to support him to try and reach out? He desperately wants to know his recipients. They did hear from a couple of them, but of course he hasn't written. He doesn't know how to put it into paper. It's just, transplant is so many big feelings all the way around. And we've just kind of been, okay, you're discharged off into the universe. So I really appreciate the map you did. I'm going to go back and study that, because that pretty much sums up everything from every angle. I thank you for doing that excellent presentation.
Thank you for that comment, Donna. Unfortunately, we're out of time here, but if people have any more comments and questions, then please feel free to reach out to Manuel at CDTRP or through info CDTRP, and we can direct them to Sean and get back to you. I want to thank Dr. Dix for making the time to deliver this fascinating presentation and for coming today. I'm really looking forward to your future research and what comes out of that. So we'll be watching more of your outputs. Thanks so much for coming.
It's a pleasure, and thanks for being a talkative group.
Take care. Bye bye. Bye now. Bye.